different actions made by the Hepatitis B Foundation and ICE-HBV. So I'm Fabien Zulim from Lyon in France, and I'm really happy to introduce Dr. Carrie Cohen, who is session chair, and she's the new president of the Hepatitis B Foundation. So we'd like to really today to hear from the community about the topics that they want ICE-HBV to address and provide appropriate information about, and we also in link with the Hepatitis B Foundation. We aim this meeting to be participative, so we want to have interaction in a relaxed manner, so please ask questions, and we have microphones and we have online chat as well. The meeting is recorded, and along the slide presentation will be shared with participants and uploaded on the website when we have the consent of the speakers. Note that there might be some journalists in the room, so if you speak on Zoom or if you have the option of leaving the camera off, and online panelists will raise your hands for the moderators to see and unmute to ask the questions out loud. So having said that, we will start with the first panel discussion. Where we will address the critical gaps in hepatitis B prevention, screening, care, and treatment in the EU. So we have a panel of outstanding expert clinicians. So we will have Marc Bourlière from Marseille, Tariq Assela from Paris, Philippa Matthews from London, and Thomas Tu from Australia. So we'll start with a few conversation, and then we will be completely open for a live discussion. So we'll start with Marc, I think, who has some intro slide. So Marc Bourlière will be, I think, on Zoom.
HBV screening, care, and treatment in France. As you all know, our current tool in terms of treatment of HBV is mainly based on two things: vaccinations and effective oral drugs. And I'm going to talk about vaccinations, and Tariq will talk about the gap on screening and linkage to care. In terms of vaccinations, if we are using the current vaccinations with the optimal regimens, so that's been 3 doses plus a first dose in more than 90% of the populations, we will achieve eliminations within 90 years. But in the meantime, we will have 80 million people who will die from liver cancer. So clearly vaccination is one of the solutions, but it's not the only solutions. And we definitely need to have very good treatments in order to achieve functional cure. And in terms of vaccinations, if we look at the result that we have currently, we see that vaccination is effective, but with a high inequality in terms of access to treatments, to vaccinations. And vaccinations reduce highly the prevalence of HBV new cases in infants and adolescents in a high-income country. It's since 1985 up to now, there was a decrease of minus 95% of the contaminations due to vaccinations. But in the low or middle income country, this reduction is only minus 74%. The other thing is that if we reduce the number of new cases among young with vaccinations, we see also that in countries in which universal vaccination is not implemented, there is still an increase of HBV cases. And the same is true for HCC. If we look at the incidence of HCC worldwide, we see an increase of HCC from 1985 to now. But if we look among infants and adolescents, we have a decrease of HCC incidence. So, and this occurs only in countries in which universal vaccinations have been implemented. So that's really focused on the fact that what we need to have and to fight for is to fight for universal HBV vaccination with a burst dose in order to reduce the incidence of the disease. And now I'm going to let Tarek talk about what we could do about screening and linkage to care, and especially focusing on Europe. Tarek, the floor is yours.
Thank you, Mark. Thank you for your nice lectures and slides and the introduction the session. We want to hear about the patient's voice, but maybe two messages to share with you about the difficulties, the barriers for screening and linkage to care. The first one, there has been many difficulties for linkage to care, and there has been one study in France, but many studies all over the world. It was called Parcours, a journey of a patient from the French NRS, and they have shown that also patients from sub-Saharan Africa, migrants, vulnerable people have less access for screening, linkage to care. So we have to reinforce all this worldwide and of course in Europe. The second message is for treatment. How many patients should be treated and how many patients are treated? And if you look to any guidance or guidelines from EASL, ISLD, or Rapazol, and you see patients who should be treated with increased ILT, increased HBV DNA, you will see that there's also barriers and very few patients are treated among all who should be treated. Another issue is also patients who are treated and should not be treated. So we need also education, medical, and also listen to the patients to improve and to fight against all these barriers, to take care and manage better the patient. And of course, implementation of vaccine. Maybe one last message is that when WHO asks a government, have you vaccine, are you doing vaccine? They will respond, yes, we do vaccine. But then we don't see about implementation and reality, and so we have to reinforce all this. So then I give the microphone to the president to open also the debate.
So now we have maybe a few words on stigma and engagement by Philippa.
Thank you. Thank you, and good morning, everyone. So I'm a clinician and also lead hepatitis B research in the UK and also internationally, particularly with links in South Africa, Uganda, and Kenya. And so have a diverse group of people living with hepatitis B that I'm fortunate to be able to interact with and increasingly try to represent. So we've become increasingly aware of stigma and discrimination as problems faced by people living with hepatitis B. And these are problems in London, in the UK, across Europe, and in many of the settings that we work in Africa. But of course, they manifest differently in different populations. But I think we can be very clear in saying that that represents a real barrier both to diagnosis and to the receipt of consistent, accessible, acceptable care. In London, there's a programme that's developed under the umbrella term of Inclusion Health, which recognises that there are many populations for whom access to healthcare is very challenging. That doesn't just apply to people living with viral hepatitis, but certainly the hepatitis B community falls very squarely into that category. And our health services are not well designed to provide for the needs of many of these populations. Education and language and understanding are often a barrier. And in fact, this is true in the healthcare community as well. So this doesn't apply to our patient population solely. It applies to the general public and it applies to healthcare workers, where narratives and messages and understanding about hepatitis B are often very poor. And we recognise that actually we're providing for the needs of people of hundreds of different nationalities, and language and cultural barriers can be really potent. Interestingly, when we did some work in Uganda, expecting to find hepatitis B being highly stigmatised, what we found is that in many communities there is no word in the local language for hepatitis B. So in fact, that's the size of the gap it's not yet stigmatized because it's not even recognized. So there are some real challenges in advocacy and education. We've also recognized that there's a lack of patient voice for hepatitis B in a way that is different from what we've seen in, for instance, HIV and hepatitis C, where there's been really good advocacy and representation of those communities. And I think for hepatitis B, we're a long way behind, and we've got a lot to learn from what's been done really well in other communities. But we've got to be sensitive to the challenges that I've raised around language, culture, stigma, the very diverse communities who are affected by hepatitis B. So again, in the UK, and I know Thomas is active in Australia as well, under the banner of Hepatitis B Voice, of really trying to provide a platform for people with lived experience of hepatitis B to bring their stories and share their experiences, so that as healthcare professionals and as researchers, we can start to do much better at filling these spaces and providing patient-centric care. And my final point really is that in this meeting, it's been fantastic to see the array of new therapeutic possibilities. And as we've had highlighted, there's a robust, safe, effective vaccine for hepatitis B. But if we're actually going to reach the people and the communities where the need is greatest, then we've got to think about how we use existing tools to the best of our ability. And there's no way that we're going to get these new treatments, which may be injectable, maybe combinations of agents, maybe 6 to 12 months of therapy. We can't deliver those into populations unless we understand what the problem looks like and are engaged with those communities and have people in treatment, in care, in a sustainable way. And so that's going to be a huge challenge, I think, for this community to make the bridge between the real-world problem of hepatitis B and the populations where this is an issue to our translational and molecular biology research programs. So I'll stop there. I think that's probably enough challenges for 8 o'clock in the morning. I'll pass back to Fabienne.
Okay, thank you. Thank you, Philippa. So now we'll leave the floor to Thomas. Thomas, too, from Australia, is a molecular biologist and a researcher of the HBV field.
Thank you, Fabian. So I've been given the easy task of summarising all the clinical trial results for the last year in 2 minutes. I think most scientists perhaps struggle to do one in 10 minutes, but I'll try. So essentially, to the community, do we have a cure yet? No. I think
a good summary.
Good summary, right? I think few have progressed to phase 3, randomized multi-center trials, and I'd urge you to keep track of updates through DrugWatch, the DrugWatch page on the Hepatitis B Foundation website. It's a really great website to keep updated. I think instead we've found that the limit to which the tools we have developed work. I think most drugs that are in the pipeline will...
Recording in progress.
Whoa. We'll only have sort of a chance of curing a small proportion of patients at the moment. Those probably already close to it, and we're pushing the balance a little to induce a cure. And of course, we're always developing new reagents and drugs in the pipeline, and that's what we've found in this meeting. So as a community member, I think you'd be forgiven in feeling a little disappointed. As someone with Hep B myself, I am too. You know, you probably already heard for the last 10 years. 5 more years. And I think this came from a more optimistic view after the Hep C cure. But I think we're really finding that Hep B is a completely different beast. It's really, we're finding out that the differences between these two viruses is as different as cleaning paint off a car to cleaning deep rust from that same car. Hep B is just so entrenched in the body, and it's really difficult to get rid of it. So what do you do with this frustration? And I really urge you not to become hopeless, but do something about it. Join us. I think we need to work together, because what's still lacking is basically funding for this to happen. We have all the scientists, all the passion, all the resources, or mental resources at least, but being able to carry out all the experiments that we need to do is still difficult. We basically still get only 1 to 10% of the funding of, say, HIV, and probably even less compared to COVID. But this disease is just as important. I think to get this, to join us, the Hepatitis B Foundation, Philippa, myself, others have started advocacy groups around the world where we help and train and help amplify the voices of the affected community to raise their voice and make a difference. And I think working together we can advocate for more changes in society and get really much closer to a Hep B cure. Thanks.
Okay, thank you, Thomas, and thank you, everyone. So now we think we now need to go more in the interactive discussion. So we still have issues with the internet connection here on the podium. So anyway, I mean, are there questions from the audience? That could be to start the discussion. While we are waiting to get questions on the chat or access to the chat. So please, John.
Yeah, so one of the easiest things that we can do right now is get the birth dose vaccine to where it needs to be. I mean, at least conceptually, that is as easy as it can be. Just to the entire panel, what do you suggest of concrete actions that we can do that starts moving that up to near where it needs to be? What can we do today to deploy a tool that we have in hand?
Thanks, John. This is a big challenge, isn't it? Because the birth dose has been advocated by the World Health Organization for some years, but we think something like 47% of babies worldwide are receiving it, and in many parts of the world where prevalence is high, the birth dose distribution is much lower. And the other problem is that the figures don't represent the truth here. So we know how many doses of birth dose vaccine are issued, but we don't know how many make it into a child's arm, which are two quite different things. I think there needs to be a unified voice from the clinical research public health communities, and not an assumption that this vaccine will get rolled out simply because it's been advocated. And I think we need more and better data to look at where that's going wrong and how we can close the gaps. I also think that there's a need for international organisations to adopt this as part of their vaccination strategy. So we know that the Global Fund and Gavi are very effective in rolling out later doses of hepatitis B vaccine. That is the standard regimen, which is typically something like 6, 10, and 14 weeks in infancy. But the birth dose has not been adopted by those big infrastructure and organisations, and I think that would be a very big step towards progress in that area. So those are some thoughts for starters.
I think also we have to involve local patient associations and local doctors. Frequently we try to implement from outside and we said you should do this as a vaccine. And finally, the best program I saw was in these countries when you have people who are really involved, wanted to make this implementation, because each country is different. We are doing educational in West Africa, and then you have many people in small village. They're going to the hospitals, but they don't get the vaccine, so they come back to the village. I think we have to look, because each local situation may be different, so to involve also many local actors, not only the Geneva WHO?
Yeah.
I think we need to involve both, because I think it's very important to implement really the burst dose at a global level. And then we have also to fight locally. For example, for the burst dose is a good example, because most of the women deliver outside of hospitals in a lot of states. So how can we implement that with the local authority, with the local agents that can really implement on the bedside, and how we can do it. And that's really the goal. On the other hand, we have also to fight on the global community, and that's why I really focus on that. The burst dose is really key if we want to achieve at least eliminations, part of the eliminations by vaccinations. So we need to use all these tools in order to improve that. But it's a huge problem, as mentioned by Philippa. This was already strongly proposed and by the community, by the World WHO from years and years. But now it needs really to be implemented into the international funding.
I agree with all the panelists that and these measures. I just want to add that this is possible. We, in Australia, have greater than 90%, I think, coverage of the birth dose, and this includes very remote areas. So these are possible, and we should learn from those models where that has been achieved.
Just to build on this, we have the tools, it's just a matter of using it, and just based upon what the panelists said, we need our voices. So right now, we have enough birth dose to vaccinate every baby in the world, but governments aren't prioritizing it, so governments aren't making it available to people in their country. And Gavi, that the organization that typically provides free vaccinations for children in low and middle resource countries, they are not providing it either. So nobody is providing it. So what we need to do is be shouting this to governments and Gavi and funding organizations to make them prioritize hepatitis B and birth dose. So, and this is where scientists, researchers, clinicians, patients, community members, if we raised our voice enough and we're loud enough, we hopefully could promote that kind of prioritization. Thank you.
Okay, so now we have, I think, a lot of questions. Antonio, please.
No, it's not really a question. I mean, I was listening to you, and I mean, to me, in my mind, it's just, do we really need to use the term elimination when we are talking about hepatitis B? We are not really putting the bar to levels that, in a way, we will honestly never achieve, and maybe try to change a little bit the expectation, and also, in a way, let people think that, I mean, if I'm thinking about patients that have acute hepatitis B that became S antigen, in reality, they have not eliminated the virus. So, and in a way, let people also understand that you can actually reach a level where you can have, yes, you can be infected, but you cannot have a disease. I don't know. I found also the term elimination a little bit shocking for me, I have to be honest. I don't know whether I share some.
Yeah.
We agree with you in the term of realistic, pragmatic, we could be said reduction of Hep B. I think it was just more optimistic, enthusiastic to say the elimination, and I think it was also taking into account all viral hepatitis or the disease. It was more optimistic, but in the realistic, we should speak scientifically only about reduction of the disease.
But, you know, WHO, they need to have goals, you know, that are optimistic.
We have to dream.
Optimistic. It's like when the community here, the research community, it talks about cure, you know. We yes. No, yeah, sure. Yeah, the reality. I mean, Antonio's point was that the reality is quite far from this optimistic goal. We agree. But we need to I mean, as it was discussed by everyone, to put all the efforts with the tools that are available. This is really what is worrisome and shocking, is that we have the tools for the prevention, and they cannot be implemented worldwide for many reasons. Peter,
one quick comment. I agree with that, and with our wording, we in Happy Voices talk about eliminating the impact of hepatitis B, and I think that is a bit more proper.
So Peter, we go one way and the other. Yeah.
I'm thinking in terms of access to vaccines, diagnostics and treatment. As horrible as the pandemic has been, has it opened up opportunities for new networks into areas that may never have been reached through, there's NGS sequencing now in low and middle income countries. There are terrific networks in place, at least at the moment, until the funding dries up. But has that provided some positive opportunities going forward for hepatitis B, do you think?
Thanks, Peter. I think there's no doubt that the pandemic has sort of polarised what's going on in this space. So on the one hand, clearly it's caused huge problems in access to care, it's interrupted vaccine programmes and so on. But you're absolutely right, I think, in terms of local enterprise, the speed at which things can be scaled up, local design, manufacture, supply, infrastructure, and so on has been demonstrated. So the challenge is how to hang on to that and how to make sure that resources that have been put into COVID can actually be collaterally used for some other challenges, including hepatitis B. As I said, having personal experience in Africa, I think what we've seen there has been phenomenal. They've now got this huge sequencing capacity, and diagnostics and drugs and vaccines are all suddenly a reality for the African subcontinent. And we've had the point really about handing back some of the challenges to communities that are facing them, rather than trying to kind of take an external view about what other nations or regions should be doing, actually kind of giving, empowering and handing back the decision making there. So I think you're right, there's a really important opportunity.
Okay, so we have a lot of questions, comments, so it's good because so we'll try to keep it short. So please, Tim now.
Okay, I'll try to be short. Thank you. Two things to say. One is to what Thomas was saying about the funding for hepatitis B and D research. And so I'd put it to the community about what I think they can do to help, and the panel can talk about what their organizations are doing to help keep the funding going. And then the other one is a more practical one, or more immediate one, and that is what we can do in terms of expanding the treatment guidelines nets and internationally. And of course, it was mentioned what we've been trying to do in the United States to simplify treatment protocols and widen the treatment. And I'd ask the panel to talk about that. So first, in terms of the community, I'll say something. And Sherry might add on. In the United States, every year, I think most of you know, the Hepatitis B Foundation representatives go to Washington and meet with elected individuals and then members, leadership at the NIH, and makes a pitch for keeping funding for hepatitis B, D, and liver cancer a priority. It suffered over COVID, as did all other non-COVID fundings. The community, I'll ask maybe Sherry to speak to this, can help, because occasionally there are actually calls on Congress to do this, the appropriators, and sometimes it's helpful to have, and this is what we use our SAMB for, advisors for, to join letters. That could be strengthened, as it has been in the other communities. I don't know how it's handled elsewhere in the world. So that's one comment and a call. And the other one was a comment to ask about the expanding guidelines, which is something that the community can do for itself. Raising the funds, we have to go to appropriators for that, but in terms of changing guidelines of treatment, that's something the community can do. Thanks.
Just maybe one comment about for guidelines, for simplify, for more treatments. We have to be very careful because in many countries, developing countries, you have no access. So if you start treatments, there are high risk of stopping with relapse, reactivation. In all Africa, the Hep B patients don't have access even of generics. So only the HIV program, they gave the treatment.
And so that should be considered in resource-limited countries about the guidelines. But I think the guidelines should establish the best practices, and then the individual countries or geographies, we have to be sensitive about how they figure out how to access them. But the most proper practices should be universal, and then each area.
I get it. Thank you.
And can I just add very briefly to that although generic tenofovir is not widely available everywhere as monotherapy, again, we should use the resources that we do have, and we have Truvada and other combination therapies, and maybe some flexibility in guidelines, for instance, to accept the use of those other agents, and certainly in pregnancy to prevent mother-to-child transmission. We have some enormous opportunities, and we shouldn't allow barriers around drug supply to get in the way of that. There needs to be proper advocacy and some joined-up thinking around what resources are available.
The infrastructure for HIV is already there, and it's the same drug. I mean,
I think you guys are speaking exactly what I was going to mention, in that today with such limited funding resources, like, is there not a way that we can join forces? And the same infrastructure that was used for COVID-19 testing and linkage to care, that's used for HIV, for hepatitis C. We can use the same, the same resources, the same infrastructure. It's just a matter of educating people and just saying it's important that we should also be testing for hepatitis B and treating hepatitis B.
Yes, but you have a big issue of durable funding, durable resources. In many countries in Africa with the COVID, they have the machine, the techniques, but then there was no maintenance. So now you cannot make any PCR in the majority of these countries. So it's not just said, it's education, etc. There's a need of durable funding, maintenance. We cannot do a PCR COVID in many countries in Africa.
I mean, I can appreciate that that's a challenge in and of itself, but in countries where, they do have the funding and they do have the ability, then they're doing it for HIV and doing it for other diseases, but they're not doing it for Hep B.
Yeah.
Sorry.
Yeah, it's true. Yeah. Ula?
Yeah, that was exactly my point as well. We are working in an EU consortium with an African partner, and we help them to establish the diagnostics. And now they are reluctant to use it because they said, what shall we do if we diagnose people who are positive? Can we provide them the drugs which WHO recommends? The drugs are available because they have all the programs for HIV, but they dare to even do the testing for Hep B. And the testing is really cheap and really easy. You don't need a PCR. You can do a finger prick for S antigen. That costs below $1 per test. And I think that's where we should start. And birth dose is certainly extremely important to prevent the spread, but talking about the community here, which is carriers of HBV, I think we need to provide diagnostics, and we provide some sort of a hope to have access to therapy, not only in Western countries.
Yes, sure. So, Ula, that's an important point, and but we need to also to be sure that once a diagnostic is made, a treatment will be available. So that otherwise, we are creating problems and ethical problems, and this needs to, just to say that this needs to be linked together. So diagnostic, point of care test, plus access to treatment, and that's a major, that would be a major goal to be achieved there. Yeah.
Definitely, but the treatment is there.
Yeah, we know.
Tenofovir is there. Yes. Yeah, so it can be applied for HIV, but people really think about getting infected with HIV to get treatment for Hep B. That's completely crazy.
Yeah. So we need to. And here, I think we need to have a strong advocacy there to change the perception of this disease, which is always underestimated. HIV comes first, and so on. And we need to change the government policies, but at the global level, so that where the HIV drugs are available, which is almost everywhere, HBV treatment should be as well. So then that would really solve the problem.
I think you're right as well. There's a strange paradox in setting up hepatitis B research in lots of settings internationally where you're prohibited from doing it because of these ethical concerns about what you do with people who are diagnosed, whereas in fact the treatments exist and we need this is the very population that we need to represent in research if research is actually to represent the real world problem. And in fact, although birth dose vaccine, as we've said, is an absolute cornerstone of elimination or elimination as a public health problem, test and treat is the single biggest way that we can actually get the burden of infection, disease and transmission down. So we must be doing it. And so I think we've got to push back really hard against these barriers that come up in saying we shouldn't be making the diagnosis because we can't treat it. It's simply not true, but I share that frustration and experience.
No, and usually we say tenofovir is there, it's generics, but in many countries you don't have health insurance. If you take Burkina Faso, Ouagadougou, so if the patient has to pay even $5, it's tenfold higher than his salary, so they cannot afford it. So even if the treatment is there, it's not available for the patient, and we face all this ethical issue. It's true also for liver cancer. We do not screen because we will have nothing to propose to the patients, so it's very difficult situations. And it's been a long time, it's more than 30 years that we heard this story about Hep B patient not having access to treatment.
So, Massimo?
Finally, we are discussing two different things. If we think of access to treatment, we have to go out from our comfortable vision of the guidelines to decide who should be treated, who not, because in some scenarios we will not have, even if we bring the molecular test or the antigenic test to see that the infection is there, we will not have the same kind of support to make decisions according to Western world guidelines to decide who should be treated and who should not be treated, being a carrier of hepatitis B. So test and treat, but first we have to change our mind. And then, at the same time, we have to provide test and access. And this is not easy at all. We were just discussing at the Global Fund initiative in Lyon 2 years ago, just before the COVID, big things, but at the end, is so varied, the situation in each country is so varied, the uptake of even the WHO objectives that is very difficult to implement. Now, let's forget this. I agree with everything was said, but is a little bit coming back to Antonio's provocation on the elimination. Do you have an idea how difficult it is to explain occult hepatitis B or the difficulty to eliminate the virus to medical practitioners? Almost impossible. And how can we envisage to change this kind of dream elimination, but easy dream to understand, when we learned a few minutes ago, but we knew before, that in many situations there is not a word to define a viral disease, the presence of a virus. Hepatitis B, they don't know what is very difficult. And they really have no representation, no word for something that is a little organism that is inside us. How can we explain that having a lot of viruses in our genome is part of our evolution and what we are? Because we carry a lot of genetic information coming from viruses in our genome, but still, there are levels of difficulty that are untouchable for me. So we have to perhaps to change a little bit the word elimination, but we cannot go very fast, more far. This is my idea. Is a kind of auto-goal, if you want, if we try to go too far in this direction.
Thank you. I know we have time for one more question, and then we need to move to the next panel session. But just to Joan. But just to respond before you go, Joan, I agree, it's incredibly complicated. But one of the things is, when you have communities that don't know anything about hepatitis B, it actually opens up an opportunity, because you can start by very, very simply educating, and we've done it in certain communities, and we've done it for other conditions and diseases too, because you don't have to overcome stigma and discrimination, right? You're starting over, so you can actually improve awareness improve education and simplify things without stigmatizing. I think we just have to try not to get bogged down in the complications, which is where we get tripped up. But it is very complicated. Joan?
I'm just going to say 2 comments. So I'm Joan Block from the Hepatitis B Foundation. The first thing is to eliminate the word eliminate, I feel reduces the goal. If we start talking about, well, let's just reduce the disease, or let's just mitigate some of the disease, then what's the point of all this research and everything? As someone, I think Thomas and I are the only 2 publicly identified people living with hepatitis B at this meeting. There may be others, but we are certainly the only 2 publicly identified. And as a patient, I want to say that would be very, very discouraging to hear the medical and scientific community saying that we're no longer seeking elimination, we're just seeking mitigation. So I just caution you on that. Semantics matter, especially when you're living with a disease that is a sword hanging over your head. We don't want to hear that from you guys. Maybe talk about it very privately over drinks, but publicly that is a terrible thing to do. Second, I wanted to just say, sorry, Antonio. But I want to give it to you real. This is why you're hearing patient voices. And I think I do represent thousands, if not millions of people who would express the same feelings. The other thing I wanted to build on what Thomas was saying is that the patient voice is extremely important. And I want to just congratulate the HBV meeting for including this patient. It started out as a patient forum, for those of you who don't remember it, in Australia. Peter Reville, through ICE-HBV, started this whole patient forum, and that's where Thomas came out. And I had already come out a little bit before. But, and then, of course, the Hepatitis B Foundation, we've been around for 30 years, and that has been our primary focus but I have to say the reason why it's so important that the HBV meeting and other organizations start deliberately, formally, officially including the patient voices, because then you can hear, when people say, well, let's remove the word eliminate, and everyone says, okay, that sounds good. Well, if you get people who are living with the disease, hopefully it's going to change your thinking. And not only that, it will change your thinking on other things, from the clinical trial designs to the test and treat to the stigma. And I think in the 35 years that I'm an old lady in hepatitis B, for the past 35 years, the patient voice has not been heard. And I think as organizations like the Hep B Foundation, Hep B Community, ICE, and all the others listed up there, as you start including the patients, that will empower people living with it to speak up. And ultimately, my final point is, it's the patient voice that is going to raise the money, at least in the US. It doesn't matter how many researchers go screaming to the NIH for increased hepatitis B funding. It doesn't matter. But if you get 50 hepatitis B patients screaming at their congressman or woman, they're going to get money. So we need to, for financial stability, for financial growth, to actually cure and eliminate hepatitis B, we need patients to start screaming. And this is a wonderful start, so thank you.
Thank you very much. Thank you. So we're going to move on. We're running a little bit behind. We're going to move on to our next session. So thank you to all the panelists for this session. I very much appreciate the conversation. So as you know, as Joan just said, there are lots of organizations working on hepatitis B in the community, and you can see we have a number of organizational sponsors today. We tried to focus each year to pull sponsors in from the region where we are, and we're in Europe today, so we have a number of sponsors from the area. So I wanted to bring up a couple of folks who can talk a little bit about their organization and what they're doing. So I would like to start with Marinella Debu, who is president of the Romanian Liver Patients Association and also a member of ELPA, which is the European Liver Patients Association, and she coordinates the ELPA HBV group. Yeah, there's already mics there.
Okay. First, I'm so happy if in the room or online, the press it is with us. Because of my experience in communication, and as patients, we need press and media in general to help us to disseminate our message. And now I will present my message from ELPA. Sorry, my English is not so very perfect, and for this reason I prepared my speech. Dear colleagues, doctor and patient, I'm so happy we have patient in the room. I'm here to speak in behalf of HEPA, a family. My message is for you, but also from all the Europe authority. The COVID-19 pandemic situation is not finished, and we think maybe will affect our life for longer, and will be a new normality in Europe. ELPA is involving in a two critical programs dedicated to patients with hepatitis. First is IP cure rate B, whose goal is to improve the functional cure rate in the chronic hepatitis B and provide opportunity for finite duration during therapy. And also liver screen, a project that aims is screening total of 40,000 people recruiting for different parts of Europe, and to reduce mortality and morbidity from liver disease. This program covers just a part of the country from European part, but the result we expect it to the next year will be helpful in all the country. Like we know and we discussed before, infection with hepatitis B is not a problem from a poor country. It is a problem from all the European countries, and it is a problem for all of us. Because I think we know if one person with hepatitis B, we must work more to increase not only vaccination for newborns, like we discussed before, but also for adults. If we don't start to vaccinate also adults, we don't have any chance to eliminate hepatitis B. In many countries, adult vaccination for hepatitis B is not a priority, and we must urgently change this. If we don't do it, the virus will continue to exist. Also, in parallel, we must stop inequity in access to testing, screening, and therapy. Many patients with hepatitis B don't have access to basic investigation and treatment, and that because they don't have money and the possibility to be insured. And I'll give an example from my home country, from Romania.
Recording stopped.
Many patients remain without any chance on being treated because of this, but also because the therapy is not accessible in their country residence. The situation is more complex for patients with hepatitis B and Delta. New therapeutic options for hepatitis Delta are emerging, promising a new hope in this infection, but after 2 years since EMA agreed on the new therapy, this treatment is only reimbursed in some countries. Unfortunately, it is inaccessible in many European countries when we know from official data we have this patient. It is impossible to don't give urgently therapy to this patient from country when we know the prevalence is decreasing according with the official statistic. In 2019, World Health Organization, European region, accounted for 90,000 new patients with hepatitis B, and part of these are with hepatitis B and Delta. Let's also not forget that hepatitis B is a risk from liver cancer. For patients with no possibility to have access to testing, screening, and new therapy, this is an additional stigma. Let's try the stigma. For patients with no possibility to have access to testing, screening, and new therapy, this is also a problem with the employers. We know a lot of patients who don't have access to work if they have a lot of preparation. I know doctors in some country who tell they have hepatitis B, and sometimes it is impossible to work if the patient will notice. I know medical assistants who cannot do work because they have hepatitis B. This is also a real problem, and we must have power to discuss about this. We must work together to ensure the availability of safe, voluntary, confidential testing for all who want to get tested and provide support service. including prevention and linkage to care. If we don't act together with one voice for elimination, the situation will not be changed soon. We must call the policymaker to put hepatitis elimination in top of the political agenda. Stop inequity in Europe now. Diagnose, treat, and prevent, because for myself, like a patient, we need to make something now in this moment. Thank you.
Thank you very much. That was really, really moving. Thank you. So next, I would like to introduce the president of the World Hepatitis Alliance, who is joining us by Zoom today. We are honored and privileged to have Danjuma Ada, who is a globally known advocate and a very strong voice for hepatitis B.
Yeah, thank you, Carrie. Thanks, Fabian, and thank you all for inviting the World Hepatitis Alliance. Good morning to all of you. I'm very sorry, my internet is quite unstable, so my voice might be freezing. I was actually listening into the conversation about hepatitis treatment, and that really reflects the challenges patients face all over the world. The World Hepatitis Alliance is an umbrella organization of over 300 patient groups across the world. As a president of the WHO, I'm also a person living with hepatitis B. The challenges patients encounter, not only in low middle income countries around all over the world, have to do with stigmatization, issues around inequalities, disparities, and poverty that restricts many of us from accessing the care that we need. And thank you so much for bridging the gap between researchers and the scientific community and the patient group. Like the last speaker, one of the speakers there mentioned, we need to amplify the voice of the patient. I live with hepatitis B and I lost my mom to hepatitis C. And I know how traumatic it is, just like many other people living with this disease, when it comes to poor access to care, when it comes to the multiple treatment algorithms and treatment guidelines that confuses the patient more as to who needs treatment, who doesn't need treatment, as to when to end treatment or when not to continue treatment. So at the World Hepatitis Alliance, we're happy to partner with the ICE-HBV Cure and the Hepatitis B Foundation and the scientific community and all other partners to accelerate the elimination of hepatitis. And as a patient, as a person living with hepatitis B, the question we keep asking, when would this cure come? So we are leaning so much and relying on you, the scientific community, the researchers, to help advocate, to help come up with these responses. And I also want to say that removing the word elimination of hepatitis really, really sounds discouraging to me as a patient. So we need to have the word elimination remain on the agenda. And treatment guidelines need to be simplified so that more people are placed on treatment. I'll say this with respect to the other panel discussion. In regions like Africa, the challenge is not just about the treatment, it's about the confusing guidelines as to who to treat, who not to treat. And that is a challenge across most parts of the world. So the World Hepatitis Alliance is happy to partner with the scientific research communities to advance the voice and the narrative and the discussion about hepatitis elimination. And thank you so much for allowing me to be part of this. And I hope that we advance more discussions towards hepatitis elimination. And as a patient, I want to find cure. I want to really have the cure. I want to know when treatment should start for every patient. Guidelines should be simplified. Languages should be simplified. We need to increase the awareness. We need to reduce more of the scientific language, make language more simpler for patients to understand. And the clinicians, please, you should understand you're treating a human being and not just an experimental tool. Thank you so much for having me, and I wish you the best in the remaining part of this meeting. Thank you for having the World Hepatitis Alliance at this meeting. Thank you.
Thank you, Danjuma. Very happy to have you here today. Next, I would like to introduce Sally Secute, who is Director of SOS Hepatitis.
Thank you very much for the invitation. Thank you very much, Marinera. It's very difficult to speak after you. You said everything. I changed my speech. I really want to add words about testing people, education, prevention, and access to treatment. All over the world, people living with hepatitis B can wait anymore. People are dying. We are trying to help families who, at the same time, have the diagnostic, and unfortunately, the liver is very damaged, so we also help family for mourning, so it's very difficult. And we want, even if we have tools. So some words about our patient association, and maybe I want also to add something. We don't want to hear anymore that hepatitis B is complicated. It's very unbearable for patients. So we have education, we understand our disease, so every health actor have to do the same. Some words about our patient organization. We are lucky because we have some volunteers. We have 25 years old. We are in France. And historically, our founding member participated also in the creation of HELPA. So we are HELPA member. And we have some regional association, active volunteers, and also serial person who goals of listening, informing, guiding, and defending people living with hepatitis B and also other liver disease, helping them to free their voices, helping them to not isolate themselves, supporting them to stay in care in daily projects, professional, family, access to loan insurance. So we are lucky in France, there are some law on this topic. We also help them for transplantation, and also, I already told that, for mourning. In, the next slide, I don't know. This one. In 2019, we initiated in France the State General of Hepatitis B around persons living with hepatitis B, and also with all civil society actors, with the main objective to better highlight the experience of people living with hepatitis B in France, their perceptions of the disease, their expectations, and to formulate proposals for a more proactive policy against hepatitis B. I will not give you all the 10 lessons to remember concerning patients' voices, but main of them, if persons haven't been screened, they don't feel concerned. But when they know they have hepatitis B, it creates strong fears. Personal life is really, hepatitis B has real impact on personal life. When half of person can count on the support of their partner, but it's still difficult to talk about the disease with friends and family. And very, very important information, trust in vaccine is not absolute, even in person living with hepatitis B. For our foundation, it's very important for a person living with hepatitis B to promote the vaccine, but it's not a reality. And long-term monitoring is difficult, even in France. So all around the world, it's very complicated. And at the end, the need for information remains important. Information on research, but also information on everyday life needs, like eating, like drinking, etc., activities. So it's important for us to gather, but we know even for patients it's difficult. So patient voices, we want you to come with us. We need you, and we have to fight again against hepatitis B. Thank you very much.
Thank you so much, Sally. And finally, last panelist in this session, we've never seen him before, Dr. Thomas Tu, who is a molecular biologist, also president of the Australian Centre for Hepatitis Virology, and will be talking to us today as the founder and director of Hep B Community.
Thank you. There's no slide for this, so that's okay. They might be a bit confused. So, a couple of years ago, I started hepbcommunity.org. This is an online forum for people with hepatitis B to join in a fairly anonymous and comfortable way from their own home to connect with other people with hepatitis B. And that came about because of my own experiences. When I was diagnosed, about 15, I felt completely alone. And for a disease that affects 300 million people around the world, that's completely ridiculous. There was no support. I couldn't talk to anyone else with Hep B. And so this is why we set up hepbcommunity.org. And we've, in the last 2 years, now grown to over 1,000 people we've helped out from across the world. And what's interesting is that the same sorts of issues come up that have come up today: stigma, how do I talk to people about it, how do I access care, all of that sort of thing. And so what we not only have there is other people, but also scientists and clinicians on there to provide that voice and accurate information. So Pietro Lompergo, Andrew Vaillant, who's in the audience today, all these people here, John Tavis, of course. And so it's been a way to provide information, but I think I speak for John, Andrew, and others. It's been a two-way conversation and learning experience. You really understand what people are going through. So I encourage everyone here, scientists in particular, to join our community. We started earlier this year an annual research showcase where we get scientists to present their work to the affected community. And it's a really good practice for the issues that were talked about in that previous talk about stop saying that it's complicated. Of course, we all know the minutiae, but being able to distill your message into those points that can be provided to the affected community is really powerful and really helpful for them not only to be empowered by that information, but know that people are around to help them, and that there's this scientific community, really passionate scientific community there to help them. So I encourage everyone listening as well, affected community, scientists, clinicians, all that sort of thing, to join hepbcommunity.org. And thank you for including us in this wonderful forum. Thank you.
Thank you very much. We are now going to move over to the panel session for people living with hepatitis B. And I know we have two people who are going to share their stories from Zoom. And I'd also like to invite Marinella back to join us on the stage. Thank you. So first, I would like to invite Carmen, who is joining us by Zoom. Carmen is a retired nurse who's going to talk to us about her experiences with hepatitis B.
Bonjour. Alors, je représente SOS Hépatite et suis référente du réseau pour la vaccination et l'hépatite B. Alors, je suis infirmière à la retraite et ai débuté en milieu hospitalier en 1968. L'hépatite B ni le vaccin n'étaient encore connus. Lorsque l'obligation vaccinale a été instaurée, j'ai bien entendu eu les 3 doses de vaccin. Un an après, était déjà entré en vigueur le fait de doser les anticorps avant de faire un rappel. Mes anticorps étant à 0, j'ai eu une injection de rappel suivie d'un nouveau dosage d'anticorps qui était de nouveau à 0. J'ai eu une injection de rappel suivie d'un nouveau dosage d'anticorps qui donc était toujours à 0 et ce scénario s'est renouvelé 2 fois. Ensuite, pendant plusieurs années, il n'a plus été question de cette vaccination. Et c'est lors d'un changement de poste en interne que le médecin du travail du nouveau site me convoque pour clarifier cette situation en rapport avec cette vaccination contre l'hépatite B. C'est de cette façon qu'on a découvert mon hépatite B. Heureusement que c'était une forme dite inactive. Reconnue comme maladie professionnelle, on a pu remonter à l'accident d'exposition au sang suspecté et être en cause grâce aux symptômes de la fatigue. Alors, ceci soulève le problème du non-dépistage avant la vaccination et le défaut de connaissance du médecin. Cette méconnaissance médicale peut être lourde de conséquences et j'aimerais citer 2 exemples pour illustrer ces conséquences. Un père de famille porteur du virus de l'hépatite B a bien veillé à ce que ses 3 enfants soient vaccinés contre ce virus suite à des dépistages négatifs pour ce virus. Il contacte l'association ne comprenant pas pourquoi ces enfants n'ont plus d'anticorps HBS quelque temps après la vaccination. Nos échanges permettent de mettre en lumière que ces enfants n'ont eu que 2 doses de vaccin. Le deuxième exemple concerne des patients, donc ce n'est pas des cas uniques. L'association contacte l'association trouvant bizarre que le médecin veuille les vacciner pour traiter l'hépatite. Alors que l'hépatite est compliquée est une remarque fréquente, mais les patients arrivent à la comprendre pour peu qu'elle leur soit expliquée avec un langage adapté et à leur degré de compréhension. Ce qui permet de prétendre que toute personne qui s'y intéresse arrive à l'apprivoiser, si je peux m'exprimer ainsi. Et améliorer le regard et la connaissance sur l'hépatite permettrait de lutter contre l'isolement, la stigmatisation et la discrimination qu'éprouvent les patients. Je vous remercie pour votre écoute.
So just to summarize in 2 words what Carmen told us. I mean, she is retired now. She was a nurse, and her hepatitis B diagnosis was done as she was practicing as a nurse, and she was vaccinated against hepatitis B as an healthcare worker, but the antibody response was not good. And finally, they found out that she didn't respond to the vaccine because she was already infected with HBV. And then she also told some story about the lack of knowledge from the GPs. So, highlighting the fact that how a GP can explain the disease, the way to prevent the transmission and to treat the disease to patients, to the community, if the knowledge of the professional is not right, you know. So these kind of things. I mean, just trying to summarize, and that we really need to educate. To raise the level of education, not only in the general population, but also in to the healthcare workers, so that the knowledge will be improved, and that in this way we can also improve all the different things we've discussed this morning. Try to prevent stigma and so on, and link, have easier. Screening, because if you don't know, you cannot screen. If you don't know why you're screening, your people won't be screened, and so on. I mean, just so education will be very important for everyone, and so that we don't miss chances.
Thank you, Carmen, and thank you, Fabien. Just so everyone knows, on Zoom, we do have simultaneous translation in both French and English. We just don't have it in the room. Next, it is my pleasure to introduce Sidi, who is going to talk about his story living with hepatitis B and hepatitis delta.
Oui, bonjour. Sidi, 54 ans, de nationalité mauritanienne. Tout d'abord, je souhaite remercier SOS Hépatite pour m'avoir permis de prendre part aux États généraux autour de l'hépatite B en 2019 et de m'offrir aujourd'hui cette occasion pour faire ce témoignage. En 1997, j'ai été diagnostiqué cirrhotique post-B delta. Et j'ai pu bénéficier d'un traitement par interféron 9 millions, 3 fois par semaine pendant 1 an. Je l'ai plus ou moins bien supporté, sauf que j'ai connu les premiers signes d'une dépression. Une dépression qui m'a fait abandonner ma thèse de doctorat à l'hôpital Michalon à Grenoble. Et un état dépressif qui a été aussi renforcé par l'accompagnement de maman pendant son parcours pour une greffe hépatique à la pitié salpêtrière suite à une cirrhose décompensée et post-B delta aussi. Il faut dire que j'aurais pu mieux vivre cet état dépressif si j'ai bénéficié d'un minimum d'empathie de la part de mon médecin. Du reste, aujourd'hui, maman va bien et moi aussi, je vais bien suite récemment à une fibroscopie et un fibroscan qui montre une séroconversion des virus B et D et une fibrose minime. Donc aujourd'hui, je suis actif, ou j'essaie d'être actif au niveau de l'Institut national des hépatites virales en Mauritanie. J'ai fait l'aller-retour entre la Mauritanie et la France. Un institut qui mène un travail honorable pour la prévention, le diagnostic et la prise en charge des hépatites virales. Toutefois, l'accessibilité aux soins reste une question cruciale. Par exemple, l'Epicludex, la nouvelle molécule ou le nouveau médicament qui traite l'hépatite D, l'hépatite delta n'est pas disponible ou seulement pour les gens qui ont la capacité de se le procurer à l'étranger. Donc, l'Institut national des hépatites virales serait très intéressé par un partenariat de recherche pour documenter un certain nombre de questions de recherche. Voilà, j'invite la communauté internationale à regarder cette partie d'Afrique de l'Ouest où la prévalence de l'hépatite B est très forte. Merci.
Okay, so I would just summarize in a few words. So Sidi is from Mauritania, and he was diagnosed like 25 years ago with cirrhosis, and they found out it was hepatitis B and delta co-infection. He received interferon therapy, high dose, had side effects of treatment. He had depression and so on. He had to stop his university education. He was if I remember well, in Grenoble. And at the same time, his mother was transplanted for a decompensated cirrhosis associated to B and delta. He suffered from the lack of sympathy from the medical community, the doctors that were managing him. He's still, phrasing this, so that's something important. Now he's doing well. Treatment, I mean, I don't know if he had other lines of treatment, but now he's seroconverted. Fibrosis is managed, and he said that his mother is doing well. So he's trying to help the community to have access to treatment, and he obviously mentioned bulevirtide, Mercludex, and the issue to get access to it for patients living with hepatitis delta. So that's just to summarize the thing.
Thank you very much, and I would like to hand it back over to Marinella.
Okay, thank you. Like I told you before, I am patient. I have patient with hepatitis B since 2006. I discovered my disease after 6 months of investigation, and I must tell you, when the doctor tell me you have hepatitis B, I have just like a liberation. I know, okay, finally I know what disease I have it, and so I was happy. After this, because I working like journalist, and I saw I lost it 50–60% of my friends, and I say, okay, this is not are my friends. And what it was good, it was because I know about hepatitis B with 1 year and 6 months before to have my first child, a boy. And I think this is very, very important to know about your hepatitis before to be pregnant, to be happy with your pregnancy. Good for me, it was my boy don't have hepatitis B. Unfortunately, I don't have access to the immunoglobulin, and so doctor in my country told me to don't break out, and I have depression. It was very difficult for me because I not feel like a full mother. 7 years later, I was involved in a patient association. I working full time. I was pregnant second time with 1 daughter. And I was full mother, but sometimes I discuss day by day with patient. I discuss also with mother who was also pregnant. Now I want to tell a story at a mother from my country, at a mother who don't was so lucky like me to don't give the hepatitis B to his children. Unfortunately, this is happened, and we must discuss about this. And also we must discuss about access to the immunoglobulin in all the country. If we want to stop it, transmission to mother to child, we must also vaccine and immunoglobulin to give to all of us, all the women, all the children who was born from mother with hepatitis B. Unfortunately, what I want to say, my boy is not responsive as a vaccination. They don't have hepatitis B. He is national champion at the speed skating in my country. He's very good sportive, but unfortunately don't respond to hepatitis B vaccine. And story at his mother. Before I got pregnant, I know I had a carrier of hepatitis B. So I consulted several specialist doctors. They all told me there was minimal chance that the baby would have hepatitis B. They all suggest me having a cesarean section and not breastfeeding. Then the baby should have been vaccinated and take immunoglobulin. I strictly followed all the doctor advice, but when the baby was 6 months old, I discovered that the baby was also carried with a rather high viral load. They have hepatitis B. I was a shock and a mental burden. I blamed myself. Please have in mind, this mother don't have possibility to put his child and to give what is very important. Another shock, it was I was finding out that for children, the only treatment it is interferon. Until he has 4.5 years old, I only keep the child under medical supervision for 6 months. And then I started this cruel treatment for 4.5-year-old children, being 3 times per week. Please have in mind her mother who must take injection 3 times per week to his child. I cried at every injection. I have him with my own hands. There were 144 stings injection in total. However, after a year of treatment, the result was no good. The viral load has decreased very little. Now, my daughter have 8 years, and we manage the disease to buy him Baraclude syrup from another country. I must to tell, we help this patient to have access to this Baraclude, and we try to have money to have from France. And because in our country, we don't have access at this therapy. We have Baraclude, but not syrup. I protect my child for other because the stigma can't affect her. In his school, in his town, in other person don't know this child has hepatitis B. Know she have some disease, but not hepatitis B, because stigmatization of the children with hepatitis B can be also a problem. And our message, like mother, it is for you, for doctor, please explain us, because sometimes with this breakdown, it is very difficult. Doctors tell us, you know, you must make cesarean, you must don't make. It is a lot of discussion, and for a mother, it's really difficult to decide what is good. Have in mind, this mother in this moment feel like it is his guilty, his child has hepatitis B. Thank you.
Thank you very much to the speakers, and we'd like to open it up for interactive discussion and questions if anyone on Zoom or if anyone in the room has any questions.
I'd like to start by thanking all of the patient speakers who spoke today. Your messages were powerful. I have a student in the room right now, and I know he is learning a great deal from you about how the efforts that we are doing to develop cures for HBV, how the real people in the world may be impacted by them. And so the first thing I want to say is thank you very much. The second thing I'd like to say is, as a father, the story you told about the little baby and the mother was powerful. So just thank you.
I don't see any questions on Zoom. Any other questions in the room?
If I can have a remark. We discussed before about the vaccination as a newborn. I don't want to have intervention because I don't know if we are in time. I think we must to start to give example of the country who the vaccination working, and we see the result. If we discuss about Romania, in 1919, the prevalence in hepatitis B it was 13%. Now it's 2 or 3. Officially it's 4, but I am involved in some screening program in my country, and I tell you, it's 2 to 5 maximum. The new data I think will be maybe in 24 later, because we develop in some part of the country with Clinical Institute Funden and with a hospital from Iași to very important screening program. And we see the prevalence is not like before. And we think this is newborn vaccination result. And we must to take this to other countries. Also, I know a lot of wonderful country on the vaccination of the newborn is not in the official program. We must to change this, because all is changed. We have migration. It's not like before 90. It's changed a lot. We have this crisis with the year. We have COVID-19. We have a lot of things, and the situation in all the Europe, people try to go what is better for here. And with this, we must to increase the vaccination and to convince adults, especially adults who have in family somebody with hepatitis B, to make vaccination, to be vaccinated.
Thank you. So, thank you. Please, Thomas. Yes.
Thank you. I just want to repeat what John had said. Yeah, really, thank you. And I wanted to ask, what has given you the courage to stand up here today and speak and say you have Hep B? Myself, in my experience, even working in an environment where everyone knows about hepatitis B and there's very little stigma against me and discrimination against me in my professional life and even in my personal life, it was still very difficult. And basically I found the courage because of other people like Joan coming up and saying I have Hep B as well. So I was wondering how you were able to do that.
Yeah, okay, I will respond. If we want to stop the stigma, we must to speak. This is first step. I talk with patients from my country. I know when you talk about hepatitis B and you see I am this patient, you know, when I have a meeting with some new, first, I go to him and I say, hello, I am so happy to see you. And second, I say, I have hepatitis B, but I don't give it to you because it's not hepatitis A. It's a different disease. I explain the difference. I think first, we like patients, we must to know the correct transmission disease and to protect us. This is first step. And to be capable to explain to others the real transmission of the disease. I know a lot of people in family, for example, my mother has hepatitis B and I don't give her my fudge, my useful. Okay, we must to take hygienical part is normal, but not so strictly. Yes, I'm here and I spoke in the name of patients from Europe like HELPA representative, but from my country, we must to have capability to tell and to explain the doctor about hepatitis. I agree with the discussion who was before. Sometimes we have problem with work doctors. You know, when we go to be employed, sometimes they don't understand the principle of transmission of disease. And we must be capable to explain her.
Thank you very much, Manuel. I just wanted to see if either of our two panelists on Zoom wanted to answer the question. What made you decide to come out and talk about your hepatitis B?
So, oh, yeah, but there's a translation.
Yeah, they have an interpreter. Okay. Any other questions? So I just have one more before you move on. And I'm sorry we keep going back to you. We're putting all the burden on you. What could we do for you? What could the community of public health professionals and scientists and clinicians and people in the room and people on Zoom, what could we do to help others share their voices and feel supported? What could we do to help?
I think first step it is you like professional who have hepatitis B to tell, I am doctor, I have hepatitis B, and I am here to help you. And I'm not afraid to tell you. This is one step, because I know a lot of doctors who don't recognize they have this disease, because it's afraid they will lose her patient. I know it's difficult, but it's reality. Second, we must to be a unite voice. For example, we have this problem with access to the therapy hepatitis delta in all the Europe. We must all to be unite voice and to tell, okay, we know the cost, and it's very difficult for you, but it will be very difficult for you when you have 10,000 or 100 of patients with cancer. We must be very united in this, and also to go in the country when the political is not so involved with this. You know, in this moment, in some countries, the political is a little bit changed because understood the COVID-19 lesson, but not in all the country. we must to work together like one voice, no matter if you are doctor, if you are a medical assistant, if you are patient. In the end, we work for patient because all of us, we are patient from one disease.
Thank you very much. And I know Carmen would like to answer the question as well. Carmen?
Oui, alors moi je crois que pour rassurer les personnes, pour partager son vécu, la meilleure façon de faire, c'est de parler de l'hépatite B comme d'une autre maladie. C'est-à-dire, c'est une maladie. C'est comme ça que j'aborde souvent le sujet. Le diabète, on n'en fait pas une histoire, on en parle librement, simplement. L'hépatite B, c'est pareil, c'est une maladie. On sait qu'on l'a, il faut la soigner. Il y a des précautions à prendre et on peut vivre avec normalement.
So what Carmen is saying is that the patients should really speak about their disease, and that this is a disease that is not different from another. So when we have diabetes, we speak about it, but not when we have hepatitis. So but there's, obviously we know these issues, but I mean, that's what she was saying. If we want to really move forward, we need a way to avoid this stigmatization and to be able to speak about it.
Yeah, but I think sometimes patients are afraid about transmission. This is, we cannot to change this. Sometimes also when we discuss with people, they don't make difference between hepatitis A and hepatitis E or hepatitis B and C. They don't make, a lot of people don't know hepatitis C is curable, and they treat this patient. And also in some country, they tell, okay, if have cirrhosis, you are alcoholical person. It's not a virus problem.
Sure, and also in the population, when you speak about a virus, they mix everything. So and it's normal. It's lack of knowledge. So they think that the hepatitis B might be transmitted just as an airborne virus. So it's like COVID or influenza, which is obviously not the case. But so people start to see very early that there's some the close friends are getting further away and so on, trying to prevent the so-called transmission from hepatitis B. Yeah. Okay, I think we had a very nice interaction and discussion. There's also, I think we've covered a lot on screening, diagnosis, access to care, linkage to care, treatment, stigmatization, raising awareness. So this is really great, and also having this this forum where people from the research community and the patient community can discuss together is extremely important, because that the patient community knows that we as researchers are doing a lot of effort to improve the treatments and so on, but that also we as researchers know why we are doing all this. That's a very important point. I think that's one point that we didn't discuss, and maybe that it could be a topic for other forums or workshops or whatever, is the place of the role of the patient community in the research. Be active in the research process. So it might be more on the clinical research side, but still having a real implication, involvement in the research projects. I think would be extremely important so that to see that you are really an actor of the research. And I think there are specific questions where you can be.
Agreed. Yeah, so I'm going to, three things. One is CD would like to talk as well. And then if we could pull up, I know we don't have it here, but there is a Zoom poll for folks on Zoom, a question about stigma. So if the AV team could pull that up on the Zoom, just so the Zoom folks could answer. And then after CD speaks, I'm going to close us out with just a couple of slides. Thank you.
Bonjour, moi j'estime que, vous m'entendez là? Moi j'estime que je suis un rescapé. Je suis un rescapé parce que je viens de très loin. J'ai été cirrhose, diagnostiqué sérotique. Et j'ai envie de contribuer d'apporter une contribution pour la prise en charge des hépatites parce que toute ma famille, depuis les années 60, surtout les hommes, on a perdu beaucoup d'hommes à cause de l'hépatite B delta et de ses complications. Donc, si je peux apporter une contribution, et je sais aussi que je suis un privilégié parce que si je n'étais pas étudiant en France et j'avais bénéficié d'un traitement par interféron, je ne serais pas là aujourd'hui à parler de mon cas. Voilà, ma mère aussi est une privilégiée parce que suite à une cirrhose décompensée, elle a pu bénéficier d'un greffon, ce qui n'est pas le cas de tout le monde.
So Sidi was saying that he was lucky and privileged to have access to treatment while he was a student in France. So he had access to interferon. His mother also had access to a liver graft, which would have been possible if they were living in their home country. And his family was impacted by this disease, so they lost a lot of mainly male members of the family since the last 50 years. For all this, he has a lot of gratitude to the medical health system, and he is willing to contribute. So that was his word. Yeah.
Thank you very much, CD. So if you can just pull up my slides real quick, and I will close us out. There we go. Perfect. Next slide, please. So we talked a lot today about what we need to eliminate hepatitis B. And remember that WHO defines elimination, not eliminating it from the body, but eliminating it from the world, not eradicating it. We're not saying we want no new cases of hepatitis B. We're talking about eliminating hepatitis B, meaning greatly and significantly reducing new cases and getting everybody who has hepatitis B into screening, testing, and care. So what do we need to do it? We talked quite a lot about what we need. We need vaccination, we need people to get screened, we need to improve access to education, awareness, linkage to care. We need to promote drug development, and as Fabienne just said, we need to make sure that we have increased communication between the community around the world living with hepatitis B and drug and clinical trial developers, thank you so much, researchers and scientists. So what are the threats? We talked a little bit about the threats as well. And I put low prioritization as the top threat because that's really it in a nutshell. If we could address, and we are working to address all of the other bullet points, we will increase prioritization. We know that there are issues with access. We know that there's discrimination. We know many people in countries around the world can't get jobs if they have hepatitis B. We know that there are many places around the world where we don't have access to cheap point-of-care tests or to treatment. The only way to change that is to improve prioritization of hepatitis B around the world. And I know we spoke about this before. We talk about lots of other diseases, COVID-19, obviously, HIV, tuberculosis, malaria, each and every one incredibly important, but hepatitis B just as important and needs as much attention and prioritization around the world. So how do we do it? What role does the hepatitis B community play? And I think the biggest thing here is voice. We heard the power today of the voices of the people who spoke out, who have hepatitis B. I would like to charge each and every person in the room, each and every person at the International HBV meeting, each and every person online to help be a voice. You don't have to be living with hepatitis B to be an advocate for it. So I'm hoping that today's event, and as we do these annual community forums each year, we are motivating more people to share their experiences, to share their voices, to tell their stories. And there are, as you see now, many, many ways that we can share stories. The Hepatitis B Foundation, it's very simple. You can go online and share your story. ICE-HBV, they're creating videos. The World Hepatitis Alliance has a place where you can share stories, and our local organizations too. So there's many ways around the world to share your voice. What we need is to unite together and demand action to eliminate hepatitis B. And with that, I would like to close out today's community forum and thank everyone for joining, and I will hand it over to Fabien for his final thoughts.
Okay, thank you. So I think I did it before you. It was more like a rough. No. Okay. Just thank you. I mean, this is an important event. I think we need to continue it on a regular basis. It's extremely. Each time I'm impressed by the impact of this interaction, and we need to continue to improve it, raise a voice together, because we are here to work together as basic scientists, clinicians, and patients to make things changing in the right direction. And we've seen so many things going on in terms of clinical care, improvement, basic and translational research, but we really need to make this applicable to the real life, and that we are able to change all these this major impact that this disease has on patients that are living with it, and that's so important, and we just need to continue, and I'm sure we will succeed. So that's the important point. If we are together and maintain our objective together, we will succeed.
Thank you, everyone.
Your sense, press release.